budesonide, mometasone, fluticasone, the most common ones. The same thing with the SADAs. We have albuterol and levoalbuterol. I'd encourage you to know the side effects and why we might choose levoalbuterol.
Right, because of tachycardia or so in other words, just like you said in the lecture, if someone's heart rate is going to be up or they get that shakiness, maybe give them levoalbuterol instead of albuterol.
Correct. Okay. I don't recall if I have a question specific about that, but you do need to understand they're both short actings, but there is some benefit to the levoalbuterol. Okay, I think you've got that. I think we're good. On your question number 3, is that where we are now?
Yeah. Mm-hmm. Okay. I'm just making little notes here. Okay. Boy, there's a lot of papers. Okay.
Yeah, I know. So, on question 3, I think the only thing I would add to it is add the neck circumference as a risk factor, increased neck circumference, and craniofacial disorders. So, disorders with the jaw, disorders with cleft lip and palate, low palate. So I would just add those craniofacial disorders. You've got the Epworth scale here, so it looks like just make sure you understand the kinds of questions that are on the Epworth scale. What are we asking the patients? You don't have to memorize it, but I see you've got it credited here, 0 never dose, 1 slight chance of dosing. That's not as important knowing what those scalable mean, but the kinds of questions. Do you fall asleep after lunch without alcohol? Do you fall asleep sitting at a stoplight? So what are our questions there? So I don't think I'm going to ask you what the scaling is, but what kind of questions are cluing you off that this patient might have sleep apnea?
I see.
Think about in treatment, the muscle relaxers, I think you've got that, except those are the things that we would avoid. Do you mean to say discontinue alcohol, muscle relaxers, benzos?
Yeah, I put avoid at the end, but yeah.
Okay, but then you've got exercise and side sleeping.
Well, we wouldn't avoid that.
Yeah, so put your avoid by your benzos, just so you get that clear. Obviously, exercise, side sleeping is important. And with, kind of know about what time of day you might want to do your exercises. Add alcohol to other things you would avoid.
Okay.
It looks like you've got it kind of in the next line. Avoid alcohol, sedative, mattress, pillows, CPAP, BiPAP, humidifier, titrate options. I think you're good there. You're just, everybody's study's different, and that's why, we're having this conversation, because the last time you really put a lot of work into a lot of things, but I think organizing it into the preparation packet instead of having to refer, it's like, okay, I got the, bare minimum under 3, but now I'm referring to a lot of other pages. As you say, there's so many pages. Try and condense that into one place.
Okay.
And then that'll focus your mind. So even if those other pages you have are not handwritten, maybe cut and paste them into under 3, if it applies.
Right.
These are just my suggestions, because we talked about what we might do to have a better outcome this time, because you obviously put in the legwork the last time, with what all you were showing me. You definitely are doing the work, but there's just some kind of disconnect between all that work and study that you're doing and that time and effort and how you So I'm going to just encourage you to kind of compress that all into one place.
Okay.
Even in your brain.
Are we gonna have any kind of questions where we need to know class 1, 2, 3, and 4? Like on here we've got pictures, but on the test I'm assuming maybe you would describe it?
Yes, on the test I would describe it. I did not insert a picture for the Malampati.
Mm-hmm.
And I'm not 100% sure I have a question based on the Malampati, but you would need to know what that looks like. Okay. So if you're doing the patient's oral exam and you notice a wide, thick tongue, a low hung palate, and you're unable to see, the back of the oral pharynx, what is that? Well, that's Malampati 4 if you can't see anything.
Got it.
So, okay. So it would be highly descriptive, but it is not an image.
Okay.
I don't have any click-on images. I think it's all multiple choice, a couple of true false, and a couple of matching.
Okay. The pneumonia one, if you, and I think you mentioned this in lecture, if you go out online, it's different than what's in the book, I think. So I put
correct. So I phrased the question that you can't miss it based on what you've read online or is in the book. I wrote the question so there's only one correct answer.
Okay. So
even if you know both, it doesn't matter. You'll still be able to answer it correctly. If you only know the book, you'll answer it correctly. If you only know what you looked at online, you'll answer it correctly. It's a very basic question, and it doesn't matter where you have the information. As long as it's evidence-based, you'll get it correct.
Okay. I did print off the, I guess it's like a chart for the pneumonia vaccine, and it depends on whether you have comorbidities or if you don't.
Exactly. And the question is phrased in such a way that if you have comorbidities or don't have comorbidities, you'll be able to get it correct. So it's good that you know that, what you printed offline, and it'll help you get it correct. It's a very basic question that I don't expect you to miss if you know that information.
Okay.
So just without giving it away, know what age you started if you have no comorbidities,
65.
and what age you would start it if you do have comorbidities.
Do what now?
Okay? And I said just know if you have 0 comorbidities, what age would you start it?
Yep,
and
that I know.
If you had multiple comorbidities, when might you start it? If you know those two things, you're good.
Yep, okay.
Okay? But I'm not going to ask you, do you give pneumococcal first or do you give Prevnar first? It'll be when you get your pneumonia vaccine.
Okay, that makes sense.
Okay?
It was two different things, and I'm like, I think she said just go with what we're studying right now and not what it said on online. Okay.
Right.
So moving on.
They flipped them in the last 2 years. So it'll just be when do you get your pneumonia vaccine, or when should you get vaccinated for pneumonia? So I because of the discrepancy, I tried to make that question vague, and you should get it right. Okay.
All right. And then on question 5, I think that one seemed a little.
No, hold on 1 second. No, I'm not. People are walking into the office like, who is she talking to?
Oh.
All right. So question 5, community-acquired pneumonia.
So I have the signs and symptoms in there, what type of exam we're doing, how to diagnose, and then the treatment as well.
Yes. I'm reading your treatments. Yeah. I think you're okay there. You might, you've got know your local resistance. So yeah, I think you're fine with that as long as you got it.
Here, the local resistance is a Z-Pack here in Missouri, I believe. But
we actually still have For sinusitis, Z-Paks just don't work. We have huge resistance. Pneumonias, you might have better luck with it. We're avoiding some other drugs, and then a respiratory quinolone could be brought in as a second line. So if the patient's just really incredibly sick or they're allergic to your first lines, then quinolone would probably be your next option.
Okay. And then on this,
So you need to know which ones are respiratory.
Do what now? Which ones are respiratory?
Yeah. So we have what we call above the belt and below the belt quinolones. So like ciprofloxacin is not a respiratory quinolone.
Right.
It doesn't cover the bulk of our respiratory drugs. But Levo and Moxie are.
Right.
So that's just, and I probably say a respiratory quinolone, but I could say Levo or Moxie.
Quinolone, I have a levofloxacin like 750 for 5 days, and a Moxie 400 milligrams.
Okay, I just didn't
for 5 days.
see it on your sheet here.
No, and it's on one of my extra pages.
Some of your what?
Extra pages.
Extra pages? Yeah. Yeah, so that's why I would say
condense it down.
Condense, yeah, because it's going to help you in the end. Okay?
All right, I can definitely type it into the questions, the main things.
Right. Yeah, the action of doing that, the way you showed me your learning style, I think is going to be really effective for you. Mm-hmm. And so a combination of, it's the act of condensing it helps bring it to the forefront of your memory. So
okay.
It's kind of why I'm
if I'm rewriting it. Okay. And then number 6.
Rewriting or even retyping, but kind of condense it down.
Well, yeah, and going back through it like that'll help it stick a little bit more too.
Correct, I agree.
And number 6 seemed kind of generic to me.
It was very generic.
So respiratory, I have just asthma, COPD, allergies, bronchospasm. There's infectious, which is pneumonia, and GI is the sphincter incompetency, cardiac is ACE beta or heart failure, and then the lung cancer, and then the treatments that go along with a cough. And I remember, I don't know if you'll have it on the test, but Tessalon pearls, you swallow it, you don't bite into it.
Correct. I won't have that on the test, but yes.
I wish you would.
Because you know that one.
Yeah, well, I tend to remember the quirky things.
Yeah, I know. I'm the same way. It's like, oh, that makes sense. Remembering the funny little poem or the little outside piece of information. Okay, so let's go back to GI. Let's simplify that. Okay. Sphincter incompetency, what is that causing?
The gastric juice is aerosol in the esophagus, and it causes irritation and a cough. Is that what you mean?
Right. So let's just make it simple and say GERD or esophagitis.
Oh.
Okay.
Yeah.
So the sphincter, I know exactly what you're saying, but it's the sphincter incompetency that's contributing to the GERD or the esophagitis. But so you're just going a deeper level of what's causing that.
What type of incompetency it is. Okay.
Yeah, just put plain language in there, GERD or esophagitis.
Okay.
Okay, so when you're trying to pull that out of your memory, you got it.
Okay.
I think you're pretty good here. Under infectious, you simply have pneumonia. I think you might want to add just plain old URI.
Oh, yeah.
So common cold.
Yeah.
And then acute exacerbation of chronic bronchitis.
Acute what?
Exacerbation of chronic bronchitis. That would be an infectious also.
Yeah, okay.
Or acute exacerbation of COPD. They're actually the same ICD-10 code.
Oh, interesting. Okay.
Yeah.
And COPD branches off into two different sections. One section is the chronic bronchitis, and the other section is emphysema. Is that
correct?
okay? All right, just double checking. And
Yep,
both,
you
and
got that one.
the chronic bronchitis and both emphysema, just for my own understanding, is that always caused from cigarette smoking?
No.
Because
No,
when
there are
you
other-
go online, that's what they make it sound like. But I'm thinking, well, there's other things, you could be breathing in that are toxic that could cause, those two things other than smoking.
Right. So I never say always, probably 95% of the time, chronic bronchitis is caused by smoking, maybe even more than that. So very, very frequently. The other thing to remember is COPD emphysema sometimes is because of poorly treated asthma throughout somebody's entire life. They may have never smoked, but they've got that chronic inflammation that damages those airways, and those folks go on to develop usually emphysema, but occasionally COPD. So I would even bring it up to 98% is cigarette smoking for chronic bronchitis, but it can be other things. So I never say always, but
Right.
almost always.
And you did say that in the lecture. Now that you're saying it, I do remember that in the lecture about chronic asthma turning into COPD if it's not controlled.
Okay, let's
the other
move down to
thing is I need to know, I had printed this off and I'm not so sure, maybe I should go so in depth, but it's the interstitial lung diseases such as like system lupus erythemus, rheumatoid arthritis, progressive systemic sclerosis, polymytosis dermatosis, Wagner's. Are those?
Yeah, that's a little too in depth. I think you just need to know the difference between restrictive airway causes and your non-restrictive airways. I don't think I went in depth on that. That's just something I want everybody to be able to refer back to that page, because you'll have this odd patient, you can't figure out why they've got these issues. And for some reason, I lost my camera. I cannot see you anymore.
Oh.
I don't know. I think so if you're showing me something, I can't see it. I can only see your, I don't think it's anything you're doing wrong. I think it's my computer, because I'm doing the, I'm not on the app. I'm on my, through the Gus Connect, and I must have timed out. So we can keep going and just talk through this like we've been doing, but I cannot see you anymore.
Okay, that's all right. So the restrictive
Otherwise, we'll log back.
Causes versus non-restrictive causes. I mean, are we just differentiating between asthma and then COPD?
Yeah,
those differences.
I think that's where. Yeah, I think that's probably as in depth as you're going to get at this level. I don't think I talked a lot about restrictive, but just think of restrictive. There's something going on that just isn't letting the lungs expand, whether, it's a dermatomyositis or scleroderma or any of those disease processes. But I don't think I think if I have a question on it, it is extremely vague.
All right.
It's not going to be identify which one of these diseases. I think if you do an autoimmune lecture next term, you'll get into deeper on that.
All right.
Okay.
So for restrictive, that's going to be something that's either intrinsic or extrinsic that's causing the restriction, I guess is the way I think about it. And then non-restrictive, would that be considered more along the lines of maybe asthma? Because it can be reversed? Or not even...
I don't think you need to go that depth. In that depth of determining between the two. Okay. Asthma would be... It's not fixed.
Yeah, it's kind of back and forth, depending on whether they're having an asthma attack or not having one.
Right. So I don't think you need to spend your study time on that. if I'm trying to help you focus, because there's so
Okay.
much to know, I think I would let that one go.
All
Okay.
right. Yeah, I better do that.
Without telling you what's on and off the exam.
When it comes to studying, I tend to go down rabbit holes, because I want to make sure I have
Yeah.
everything covered. So we'll move on
Right.
to
I think
question
let's-
7.
Yeah.
I typed in a lot of stuff there. So is there anything there that looks like I'm missing something, or I need to narrow down on one more than the other?
All right, let me kind of look through here. Okay, so let me make sure I'm not missing it. The font's getting kind of tiny here.
Yeah.
Just make sure you can differentiate between classic and common migraine.
Mm-hmm.
Okay, I think it's just you get your bullet points off kind of funny.
I do.
Okay, so I want you to definitely know one of them has an aura, one of them doesn't. Okay.
Yep, and I've had migraines, so I already know that. I know. I used to get auras. So the one that has auras, I know, is the classic migraine, what I used to have.
Mm-hmm.
So I mean, it helps maybe having it.
Right. Just make sure you can. And a question: if we're describing what type of pain that patient's having, how long it's been going on, how often it occurs, when it occurs, does it fit into common migraine, classic migraine, tension, cluster?
Mm-hmm.
Really, the way you have this laid out is fine, but looking, going back to those images you showed me when we met the last time, I think if you put this in a compare and contrast chart, where your one headers would be all your different migraine headache types, classic, common, tension, sinus, rebound, and then under each thing, symptoms, timing, treatment. That might help you organize your thoughts versus having this in table format, because the whole thing is compare and contrast.
Right.
So what things are the same with the headaches? What things are different? And depending on how you learn, this could easily be done in a table or in a concept map.
Okay.
Okay, because the way you got it now with listing, once again, I'm only going from how you showed me you studied the last time. I think you would do better
having some type of a chart that differentiates.
Yeah.
Okay.
Yeah, because that's how, you were telling me you learned the best, and I think it very well may be. Okay?
Okay.
But the information you have here is correct. Okay?
All right. I
think your information is good, but if you want to dedicate some time on studying it, that's how I would recognize it.
Okay.
Red flag headaches. Let's see. You've got encephalitis. You got meningitis. So you've got stiff neck here. You can get a stiff neck with a tension headache. So let's have you go take a little bit deeper dive. What are the names of those tests? What happens when we move their head or neck? Those are all red flags that you should be able to say the patient has it or does not have it. If you're seeing this headache patient in your office that mom or dad brought them in because they got a terrible headache, there's some tests you would need to perform to tell you this patient goes to the hospital or this one goes home with, your set.
I
so why don't you go back in and actually
look
review
for the actual diagnostic test?
Yeah, not the imaging, but what procedure, what
like a maneuver,
exam
kind of like when you're the one where you have the ear stones, so to speak, and they drop your head down and turn it
that
to
would
the
be
left
like
or right.
Right, but remember, if you flex the head, what happens to the knees in these meningitis patients? So get back into that. Some of that may be in your Dane's text, I think, might
Okay.
be even clearer. I can't remember where that's at, but you probably ought to be able to know those for meningitis. Think about what sort of risk factors that patient might have, close living quarters, versus encephalitis. What causes encephalitis typically, So, insect bites, know the classic rash that you see with meningitis, the type of rash that would be more common with that. Okay?
Okay.
I think you're right on subdural hemorrhage, subdural hematoma. Add to that, what are the risk factors for it? Well, obviously injury, anticoagulant therapy, those sorts of things. And then how long does it take for them to occur after the event? Subdural being a slower, more insidious onset, where subarachnoid typically much more sudden, like you said, thunderclap, headache. Okay. Yep. All right.
We're getting
Just
there.
because we only have 11 or 12 minutes left, let's keep moving through. Okay.
Sounds good. And I guess down below I had medication and drug related, CNS stimulants, beta agonist, and listed them out.
Okay.
Other causes of tremor, 50%. Did I get these mixed up? All right, so we're going to go on to 8. What did I do with 9? I think
I see 9. I'm looking for 8.
Oh, I just looked at
red
8.
Flags. Okay. I don't see. Hold on.
I think I might.
Yeah, there's 8. So let's go down to 9.
Where's my 9 at? I've been studying, so I hope I didn't misplace it.
Okay, you've got 9 underneath the table that you inserted for acute, subacute.
Oh, I do. You're right. Yep.
All right. It's just on the same page. So you know what it is. What does it look like? All right. So if you have a resting tremor, I can't tell. Tremor at rest. Oh, okay. So you say resting tremor is a tremor at rest, intentional tremor when the patient's making a voluntary movement. Parkinsonian, you've got resting tremor off in one hand. You've got cogwheeling. Work to remove the offending drug if it's a Parkinsonian, not Parkinson's disease, but Parkinson related. Now, I don't know if you see cogwheeling with drug-induced Parkinsonian versus Parkinson's disease. You definitely have the cogwheeling. I will not ask you that question, by the way.
But it's just something to remember. Okay.
Yes, because I'll probably have cogwheeling somewhere in there.
Now, if you have cogwheeling in there, I mean, on my review, it's definitely associated with Parkinsonian type tremor or issues.
Right.
But you're saying you won't go so far in depth to ask, cogwheeling, is it induced by drugs or not? Which it wouldn't be.
Correct.
Right? Okay.
Correct. I would not ask that.
Okay.
So you got your differentiation of tremors. I think you're good, because I think later on we get down to the actual different diseases, Parkinson's, Alzheimer's. So I'm scrolling down here. Okay, causes of vertigo. This is another one I'm sure you have, it looks like you have good information here, but I definitely think you can either do it this way or you can put it into a table format. But it's up to you. Just make sure you fill in your acoustic neuroma and labyrinthitis. I definitely have questions where this may be a matching question. I don't recall.
Okay.
Where, you might have acoustic neuroma, labyrinthitis, vestibular neuronitis, and Meniere's disease, and then match it to the symptoms or the causation. Okay, so make sure you fill in those two. Zoster, let's see, I'm on 11 now.
Okay.
Just because I got the patient in 9 minutes. get the rash down correctly. Chronic, often not needed, but you could do the viral or the PCR, IgM. Good treatment options. Remember, we want to get those treatment options on in what time frame from the time of diagnosis to help prevent.
I have 72 hours. Is that wrong?
Yep, that's correct. You got it. I didn't see it. I'm down to about an 8 font here. So
well, I was trying to pack everything in there.
No, I should have just enlarged my screen. It's fine. If that works for you and your young, healthy eyes, go for it. Okay. So I'm moving down to 12 because you looked pretty good there.
Okay.
Got the bradykinesia, drooling. Okay. So when I open this, it's just your bullet points for your stages looks off, but I bet it's right on your screen.
It's yeah.
Version. So just to help you study, you want the act of going through and making those little corrections.
Well, it'll be, if I go through there and I make the tables and everything, then I'll be retyping and I'll be understanding it even more. So I don't mind doing that.
Yeah, I think you're doing good. So all those stages, I'm probably you're not gonna have to recognize the different stages. Really just what is our early treatment option that you potentially might start in primary care. So know your first drug, which you got it there. And then refer. Identify, potentially start a drug, and refer is what our job is in primary care. You probably want to know some of the new, drugs that are used for other things. Once again, we're getting down to some kind of tiny font. So.
Yeah, with the early treatment option, I'm gonna assume that's gonna be like a stage, even if it's a stage 1 or 2. Am I going to need to know the actual dosages of levodopa and carbidopa?
No, you'll just need to know the drug. What would you start with? Okay, which is your carbidopa, levodopa. Mm-hmm. Okay?
Yeah.
You probably have more than you need under amantadine. That's a lot of information under amantadine. It's a rarely used drug. Okay. So don't spend too much time. Looks like you got it listed as an anticholinergic and an antiviral. So remember, amantadine is not an anticholinergic drug. I'll pull that out. Put in your anticholinergic drugs and why you might use them, usually to deal with the drooling. But so pull that out, fix that around. You got amantadine again. I think you've got. I don't know if you cut and pasted.
I did.
Or what, but. Okay, you need to fix that.
Okay.
That's not helpful. I'll let you go back and completely rework that one, okay? All right. So restless leg. So think about what is our diagnostic workup. What kind of things can cause restless leg syndrome? We talked about one of the number one causes is iron deficiency. So you would do a CBC, you do an iron profile, maybe a ferritin. B12 deficiency can cause it. Hypothyroidism can cause it. So when we're talking about the diagnostic workup, it's those labs.
Okay.
Then combined with the patient's self-reported symptoms, which you have listed here that are really good. You may refer to polysomnography, but not necessarily. Okay. And then you've got some good stuff about rule out leg cramps, arthritis, other causes. So I think you're good there, but just know those labs. You're good with your treatment options. So I think you're okay there just to add the laboratory workup that you might do for RLS, because iron deficiency certainly can be an issue. Alzheimer's disease, you need to plug in your screening tools. So mini mental, which can be performed in primary care, the short blessed, maybe some caregiver strain questions. Pharmacologic therapy you've got there. You might want to know your side effects and who you would be careful with diazepam on. We talked about that in lectures. So add in the risk for diarrhea, worsening peptic ulcer disease, people that have really uncontrolled asthma, because just know the class of drug it is, and then you'll be able to figure out who you got to be careful with, because this increases acetylcholine. You're good on your Namenda. Yeah. Okay. So is this all the questions? Yeah, 16 and then 17. Yep, I have 17 questions.
Okay.
So the exam has 40 questions. Like I said, the bulk is multiple choice. I don't think I have any multiples. I may have some none of the aboves or all of the aboves. So I will caution you, be really careful. There's a couple of questions that are worded, all of these except. People mess those up sometimes, when there's an except question.
I do. Okay.
Yeah, so I tried to capitalize except, bold it, something to draw your eye that it's an except question. You'll be able to go back, so I think that's going to really help you.
I think so too, because whenever I get stuck, if I get stuck right away on something, I like to be able to go back to it, because
Sure.
if I spend too much time on it, then it makes me stressed for the rest of the questions, I guess.
Right. Exactly. No, I understand completely. They asked us not to go back just to maintain test integrity, but we're not giving you enough time to phone a friend.
Right.
And I have to trust that the graduate student, hopefully every one of the graduate students understand, you got to know this stuff.
Right.
Because
well,
you pay a lot of money for a master's degree.
Yeah, I do have a small
exam.